All right, everybody, that's the top of the hour, so we're going to go ahead and get started right now. Thank you for joining us this evening. We've got a great presentation in line for you. My name is Rich Groves, and I'm here on behalf of the Next EDS. I manage our professional affairs, and means I get to do a lot of great things for the organization, build some content for you all, and in occasions like this, get a chance to introduce you to a fantastic speaker, an authority in the topic that we're really going to be focusing on tonight. We're going to be talking about biofilms and their connection perio-systemically. Dr. Kurtzman is our featured speaker this evening, and Sunstar has brought him to you all, so special thanks to them for making this possible. Dr. Kurtzman is a very well-respected researcher, lecturer, speaker, has written more than 500 different publications through his time in dentistry. When he invests in a topic, I think you're the ones that benefit from that. And tonight, that you're the beneficiary as it relates to some related conditions, prostate, pancreas, liver, women's health. We're going to talk about a variety of those topics as they relate to the oral biofilms. Just a couple of quick housekeeping issues before we get to turn the mic over to Dr. Kurtzman is we'll have a didactic part of the presentation, and that'll last about 40 minutes or so this evening. During that time, you can ask questions anytime you like using the chat function or the Q&A, and we'll hold all those questions at the end and let Dr. Kurtzman address as many of them as we have time for in tonight's program. We're also going to conduct a couple of live polls so that you can participate and share some of your feedback with us. And if there's any questions you have, we'd be more than happy to tackle all of them. And so without further ado, it's my pleasure to welcome our featured speaker tonight, Dr. Greg Kurtzman.
Hi, and welcome to part 3 of this 4-part series on oral biofilm and the systemic connection. And just a little bit about me, I basically have sort of got involved in a lot of writing and stuff, and I sort of say, I kid around and say I'm a dental writing idiot savant. It's my hobby. I don't get into sports, but I do like dentistry, research, and writing about it and educating people. So this is the 4-part series. In part 1, we talked about oral biofilm inflammation, the oral health connection. Part 2, which was the last part we did, we talked about systemic effects of oral biofilms, cardiac erythromas, kidney, pulmonary, diabetes, colon cancer. And basically what we did was we talked about increasing evidence linking chronic inflammation and infection and cardiovascular disease with the biofilm as a predisposing factor. And the body's response to periodontal infection includes production of inflammatory mediators, which travel through the circulatory system and may cause harmful effects on the heart and blood vessels. And a lot of this is really showing up in the literature in increasing amounts over the last probably 5 to 10 years. So I think that we're finally seeing the connection by what goes on in the mouth with the rest of the body. Because oral biofilm can inoculate the respiratory tract when aspirated, and this is really critical in senior citizens, especially those in nursing homes or in assisted living. That's why a lot of these patients wind up getting pneumonia, and it may be coming from the oral biofilm that's on their removal prosthetics or just poor oral hygiene that they can't maintain these things. So we have individuals that have diabetes. There are 2 times the risk of periodontal disease as those without. And we find that treatment of periodontal disease does improve their glycemic control. So it's sort of hand in hand. If you basically have diabetes, you're more likely to have perio problems. If you have perio problems and diabetes, if you get the perio problem under control, you're going to basically get the diabetes under control. And I think that what we find with this is that those patients who are on the medications and they just can't get their blood sugars regulated, there may be a dental link, and if we get the dental and perio under control, that may help them get the diabetes under control. So we're basically going to move on to this part where we're going to talk about more systemic effects of oral biofilms, which, as Rich said, prostate, pancreas, liver, pregnancy, fertility issues, Alzheimer's, and artificial joints. And then we'll move into the next and final part of the series. We're going to talk about what do we do and how do we treat these and how do we prevent dental and systemic issues. So here's our agenda today. We're going to basically talk about prostate. PSA, or prostate-specific antigen, plays a critical role. We're going to go into pancreas, the role of inflammation from a periodontal disease may promote pancreatic cancer. The liver, the most important function of the liver is to remove bacteria from the blood. And pregnancy and fertility and menopause. And women with periodontal disease may increase the risk of having preterm births. And of course, we've found links recently that have been talked about with Alzheimer's, how chronic inflammation may cause tissue damage, including the brain tissue. And finally, we'll talk about artificial joints. Researchers have discovered tooth bacteria in the synovial fluid of patients requiring joint surgery. So we'll move on from there. So the systemic connection, harmful bacteria strains, in the oral biofilm can enter the bloodstream, causing an inflammatory response and travel to other areas of the body. So what's happening in the mouth is not just confined to the mouth, it basically moves throughout the entire system. And this exerts a distant systemic effect that has been linked to numerous diseases, as we said, cardiovascular disease, respiratory diabetes, as we discussed in part 2. Evidence indicates patients with periodontal disease have a much higher risk of developing cardiovascular disease and other systemic issues than those who take preventative measures to control the biofilm in their mouths. And as we get older, and especially if we have older patients or family members, we may want to emphasize that to have quality of life as we're getting older and we get into our 60s, 70s and up, and people are living longer, basically is we need to basically take better care of these things. And unfortunately, when patients are relegated to nursing homes or assisted living facilities, they're not tending to get regular dental care, and especially those patients who have full dentures. You know, basically the family looks at, well, they don't have any teeth. What are they going to go to the dentist for? They need to really take better care of those dentures so we don't have stuff growing on them that they could potentially aspirate. So managing and maintaining the periodontal environment can have general health benefits, preventing systemic issues, decreasing severity of these systemic issues already present. So let's talk about the prostate. Prostate-specific antigen, also known as PSA, is an enzyme created in the prostate, normally secreted in very small quantities, has been reported to be secreted at much higher levels in men with periodontal disease. And inflammation of the prostate, or when infection is present or affected by cancer, demonstrates elevated PSA levels. So unfortunately, men, as we get older, we tend to see our PSAs tend to go up. And it's interesting because I had a friend who, 1961, was diagnosed with cancer. They gave him 6 months to live. He said, BS. He basically started doing mega doses of vitamin C. Well, he runs into Linus Pauling, who, as you might know, won a Nobel Peace Prize. And they're talking, and Linus Pauling was a very big advocate of vitamin C therapy. And they're talking, and Linus Pauling says to my friend, he says, well, how much are you doing a day? And my friend says 50,000 units. He goes, and you're not having a problem? He says, no, absolutely not. So actually, Linus Pauling elevated that. Well, he's on this talk show. He talks about that. He says, oh, I'm doing 50,000, no issues. And Linus Pauling at the time was in his 90s. And he said, yeah, you're having, he goes, well, I'm having some prostate issues. And they said, oh, so see, this isn't working. He goes, no, all men have prostate issues at some point. Mine didn't hit me until my 90s. A lot of men get in their 50s, 60s, and 70s. So I think if we take care of ourselves, we can help this. And the prostate is one of those things that we can take care of. So research demonstrates men with indicators for periodontal disease and prostatitis have higher levels of PSA than men who do not have periodontal disease. Elevated PSA levels are a classic indicator for prostate cancer. And this is one of those things that you really, as a man, once you hit 50, you really have to start having these things checked to catch things early. And there are ways of treating these things before they get to that level. But as we said, control the periodontal disease, we may control the prostate issues also, help lessen the severity of those. Pancreas. Pancreatic cancer risks include factors including cigarette smoking and chronic pancreatitis, but the role of inflammation from periodontal disease may promote this cancer. Harvard School of Public Health and Dana-Farber Cancer Institute, researchers found that the periodontal disease may be associated with an increased risk of cancer of the pancreas. And it's interesting because my grandfather actually in 1973 died from pancreatic cancer. And a couple of years ago, probably about 10, 15 years ago, my cousin, who's an eye surgeon, we're talking, he says, I did some research in this and I don't understand it. It's, how could he was a tailor, how could he have gotten pancreatic cancer? That's from organic chemicals. And I said, you remember that house they had in Connecticut, he used to spray Agent Orange, which has been linked to it, all over the place. They didn't wear gloves, they didn't wear masks, and that led to it. I'm not sure if he had periodontal disease, because I was 13 at the time, so I can't answer that. But there are things that we can basically look at to minimize problems. And some of those, as we're saying through the series, is get the mouth healthy, we keep the rest of the body healthy, or healthier than it would be. Additional research with periodontal disease had a 63% higher risk of developing pancreatic cancer compared to those reporting no periodontal disease. So this may be something we may want to really impart on our patients. If you're having some health problems, you're getting up in that age, if we take care of these things, get your mouth healthier, that may give you better quality of life and have fewer problems as we progress down the road.
And that is my cue. Thanks, Dr. Kurtzman, for getting us off on the right foot. We're just going to interrupt that helpful dialogue for a moment and ask you all a quick question. I'm going to open up the poll real quickly and ask you what aspect of the systemic connection is most interesting to you. For those of you who are not necessarily on your phones tonight, we'd love to take your temperature and get a feel for it. Are you interested in how the oral bacteria manifests and travels systemically? How systemic disease is linked to periodontal health? Factors involved with periodontal disease, that would be high-risk patients, preventive measures, things of that sort. Or is it oral health instruction and working with patients to improve their health? Just a quick poll check. I'm going to leave it open for just a few more moments. We don't want to take you away from our great speaker tonight, but I'm interested to hear some of your thoughts. Okay. This is actually going to be pretty interesting. Okay, everyone, just a few more seconds here. I'm going to close the poll down. Okay, and the number one answer, how the oral bacteria manifests and travels systemically.
You know, it's interesting because I started dental school in '82, and prior to that, we were considered tooth mechanics. We took care of everything in the back of the throat to the lips, and we didn't concern ourselves with anything else. And just prior to me starting dental school, they started really educating us more in the medical side of it. And I think they started really looking on us as we're healthcare providers, just like physicians. We just specialize in a different area of the body. And I think that it's progressed even more over the last 30 years. And I think that finally, I think the younger physicians that are getting out recognize that we're part of the healthcare team and that we're there basically to work together. Unfortunately, some of the old-time physicians, and most of those guys are retiring, still look on us as tooth mechanics, but I think that the younger physicians are really looking on us as colleagues.
Fantastic.
So let's talk about liver disease. The oral cavity is a reservoir for more than 700 bacterial species. These bacteria, especially the periodontal bacteria, can spread through blood and reach further organs. The most important function of the liver is to remove bacteria from the blood. Therefore, bacteremia produced from periodontitis could be a serious source of infection in the body in persons with liver disease. So what that's basically saying is, if you have a healthy liver, we may have some issues, but if you have a liver that's having some problems, the periodontal disease may make it worse because now we're seeding that liver that is not really as healthy as it should be with bacteria that can lead to some other problems. Infection with periodontal disease is associated with the progression of atherosclerosis, that's a tough word to say, fatty liver disease, which is one of the causes of atherosclerosis, and periodontal diseases may also be implicated in the pathogenesis of non-alcoholic fatty liver disease. The correlation may exist between patients with periodontal disease and liver disease, and if you look at everything we're talking about, there's a lot of correlations between a lot of these systemic things and what's going on in the mouth and the bacteria. I realize I keep repeating this, but it's something we really need to overly emphasize. And, you know, if we look here at the systemic manifestations of acute liver failure, we can basically see it affects a lot of parts of the body. So we're a fine-tuned machine for the most part, And if we basically start messing with one part, it affects a lot of other parts of the body. Pregnancy, infertility, and menopause is interesting. Pregnancy issues, women with periodontal disease may have 4 to 7.9 times the risk of having a preterm birth in women with good oral health. That is considered a moderate risk factor. And basically, at least when I was in dental school, and I'm sure that it's still emphasized, the term pregnancy gingivitis. As hormones increase during pregnancy, the tissue becomes more susceptible to inflammation. So a little bit of irritation from plaque or something, which is what we're referring to now as oral biofilm, that normally if somebody is not pregnant, their hormone levels are lower, may not affect something, but as they get further into the pregnancy, that little irritant and that bacteria causes more and more of a problem. And basically that crosses the placental barrier and can affect the fetus, leading to early term pregnancies or delivery. So early identification and treatment of periodontal disease during pregnancy may reduce the risk of premature birth and low birth weight. Evidence links an association between the presence of periodontitis and preterm delivery in low birth weight infants. So basically what we want to do is emphasize in those patients of ours who are pregnant, they may want to come in, depending on what their mouth looks like and the inflammation level, they may want to come in more frequently during that pregnancy. Instead of every 6 months, we may want to see them every 3 months or maybe even every 2 months if it's severe enough, just to keep those levels down so that we basically don't have it transferring over to the fetus. Because biofilm inflammatory molecules can enter the circulatory system and cross the placenta to reach the fetal membranes and cause preterm delivery. So oral bacteria has been identified in fetal membranes. Moderate association has been generally found to be between periodontal disease and the different adverse pregnancy outcomes have been reported. So we basically have to start looking at these things, that we're really the preventative people to help other systemic issues from getting worse or causing problems. Inflammation of the periodontal membrane due to inflammation of the biofilm increases dramatically in size and severity during the course of the normal pregnancy. As we said, hormone levels increase. It just takes a little bit of biofilm or plaque, whatever you want to term that, to basically trigger something, the inflammation, and it just snowballs from there. So lipopolysaccharides from cell walls of periodontal pathogens can trigger production of prostaglandins. Periodontal infection leads to release of these prostaglandins into the circulatory system, and these stimulate oxytocin production, which can initiate preterm labor and result in lower birth weight in babies. These prostaglandins stimulate oxytocin production and can initiate this, and pregnancy can influence gingival health. Changes in hormone levels during pregnancy promote an inflammation termed pregnancy gingivitis. So what we want to do is we want to get those patients in when they say, hey, you know, I'm pregnant, get them in for a cleaning, exam, explain this. You're going to have to do a little better job. We may want to see you a little bit more often. If you start getting some gingival bleeding, you really need to come back in, get a cleaning, so that we can basically keep these effects down so it doesn't cross the placental barrier and affect the fetus. During pregnancy, due to these changes, there are certain systemic propensity to periodontal problems. The most pathogenic bacteria, the biofilm, tend to increase in numbers, and also due to increased vascular permeability, these bacteria and their products can more easily enter the bloodstream and spread to other parts of the body, such as the fetus and placenta. Infertility issues, and this is really interesting because this is really starting to come out. Periodontal disease causes systemic inflammation, which is systemic rise in pro-inflammatory cytokinins and decrease anti-inflammatory cytokinins that can interfere with fertility, possibly due to preventing ovulation, preventing implantation of the embryo, or not sustaining its implantation. So if we have know somebody or have a patient says, hey, we're trying to get pregnant, I'm not able to do this, I'm considering doing fertility treatments, which are expensive. Insurance covers some of it, some insurance doesn't cover it. We may want to recommend, why don't we try to get your mouth healthier and then see if that helps. If we could basically control all these things, that may be having an effect on your fertility, and that may allow you to get pregnant without having to go the direction of fertility treatments. So there's one study by Dr. Roger Hart, who's the professor of reproductive medicine at the University and Medical Director of Fertility Specialties in Western Australia, suggests that gum disease might be one of several factors that could be modified to improve the chances of pregnancy. Women with gum disease average 2 months longer to conceive than women without gum disease, 7 versus 5. Non-Caucasian women appear to be in the group most affected, and they are likely to take more than 12 months to become pregnant if they have gum disease, and that's from Dr. Hart also. So non-Caucasian women were the most affected because they appear to have the highest level of inflammatory response when suffering from gum disease. And receiving treatment for gum disease while pregnant does not affect the health of the fetus or the mother. In fact, it's the opposite. Not treating it and having those bacteria in the products crossing the placental barrier, getting out into the system is going to have more effect than coming in for a cleaning. But women get a little paranoid in that, like, well, I'm pregnant, I don't want to do anything that could affect the fetus, and might affect my pregnancy. So they're basically actually leaning in the direction of what would actually affect them versus getting some treatment. So those having conceiving issues may wish to have their period evaluated and treated to remove the systemic inflammatory component of oral biofilm prior to considering infertility treatments. So you basically say, hey, let's get the perio under control, let's see what happens, give it a couple of months, see what happens. That doesn't work, then consider the infertility treatments. Because infertility treatments don't always work, and they're expensive. Post-menopause, data from 65,869 women between the ages of 54 and 86, women who reported a diagnosis of periodontal disease had a 14% higher risk of developing any type of cancer. Higher risk associated with periodontal disease was esophageal cancer. Women with periodontal disease were 3 times more likely to develop esophageal cancer compared to women without periodontal disease. So, you know, unfortunately, as we're getting older, there's a lot of issues that are there, and they start to compound. And a lot of this, like we've said through this series and through this part, if we get the periodontal disease under control, we may be able to lessen these problems or maybe even eliminate them completely. The elderly are more disproportionately affected by periodontal disease than any age group and most types of cancers. So as we get older, we tend to see more cancers in just any compared to any age group. Adverse effects of periodontal disease are more likely to be seen in post-menopausal women simply because of their older age. Chronic inflammation has also been implicated in gallbladder cancer. There has been no data in the association between periodontal disease and the gallbladder risk at present. We may see this come out in the next couple of years, a definite link, but there's speculation that this may be, there may be a causal link there, but they haven't been able to prove it yet. And as we can see, basically inflammation affects cancer, cardiovascular disease, Alzheimer's, pulmonary disease, arthritis, autoimmune diseases, neurological diseases, like, you know, we said Alzheimer's, but there are others also, and diabetes. Now let's go to Alzheimer's. Alzheimer's is basically, we're seeing really this talked about a lot over the last few years, more increasingly because we're seeing more people in the population coming down with these symptoms. Its chronic inflammation causes tissue damage, including the brain tissue. This can contribute to development of brain disorders, and I'm sure that we all know somebody either directly or indirectly that has developed these issues. Patients with periodontal disease at an early age had a higher incidence of Alzheimer's disease, and connection between chronic systemic inflammation and degenerative brain disorders has been found. Periodontitis can be marked as a low-grade systemic disease by release of pro-inflammatory cytokines into systemic circulation and elevation of C-reactive proteins. Inflammation is known to play a pivotal role in both the disease process, serving as a connecting link between periodontitis and Alzheimer's. And I think that if we get these things under control at an earlier age, we're going to basically see the effects later on. I'm not sure that, you know, if somebody is developing Alzheimer's, if we're going to eliminate Alzheimer's, but we may slow the progression down so that they're basically, it's not worsening over a short period of time. We may be able to prolong that as long as possible. Elevated blood inflammation is predictably a risk for dementia and incidence of cognitive impairments. Studies have revealed that dementia in subjects of poor oral health and periodontitis that leads to the presence of inflammatory molecules in systemic circulation is thought to be a definitive risk factor for developing a variety of systemic diseases, including Alzheimer's. So everything, as we said, everything interconnects. Periodontitis has a tendency to infiltrate the systemic circulation. You figure when we have periodontal disease, we're opening up the blood system. It's through the capillaries, the bacteria and the products get out into the system. And it's always been advisable to prevent periodontal disease progression to prevent further systemic outcomes.
All right, that's my cue. Thanks, Dr. Kurtzman. I'm going to pause just for a quick moment, folks. We want to open up our second poll tonight. I'm going to ask you just a quick question about your focus as a future professional. Are you interested in the diagnosis? Are you interested in some of the research? Or, as many of you, and you're asking questions already tonight, we can see that you're maybe a little bit more interested on the professional care or the patient's home care and how to bridge those two activities as a care provider. So we're going to leave the poll open for just a few moments and allow you to comment and share some of your thoughts with us tonight. All right, keep them coming. I know those of you on your phones don't have an opportunity to participate, but if you're in front of your computer, all right, keep going. Got it. Diagnosis and research, or are you on the care side? We'll leave it open for just a few more moments. Seconds and counting. Okay, everyone. Thank you for that feedback. Really appreciate it. And on we go, Dr. K.
No, you're not going to tell us what the most popular answer was?
Sorry. Actually, the most popular answer was the diagnosis and the research.
If you want to close that box.
Got it.
Thank you.
All right.
So that close it. There we go. Artificial joints are important because as we're living longer, more people are getting hip replacements, knee replacements, and other joints, but those are the two most popular, or the highest percentage are knees and hips. And, you know, it's also important. Over 65% of all human infections are associated with biofilm related. Shedding of oral biofilm bacteria and systemic dissemination have been associated with bacterial seeding and subsequent infections distant from the oral cavity. Now, researchers have discovered bacteria that normally resides on teeth in the synovial fluid of patients requiring joint replacement surgery. And the concern is that, you know, if we're going to have a joint replacement, what do we do? And my opinion is we need to emphasize to these patients that, all right, you've had your hip replaced, you've had your knee replaced, you want this to last as long as possible. The way to do this is we have to prevent bacteria from possibly seeding in there, and a lot of bacteria in the mouth, and if we take care of your mouth and you do a lot of better home care, we can prevent you from having to have this hip or knee replaced again down the road. So oral bacteria are likely what we call a septic loosening, the most common cause of long-term failure in hip and knee replacements. And basically what occurs is when normal wear of the prosthetic joint produces microscopic debris particles that trigger an immune system response that causes artificial joints to fail within 10 years with no identifiable source of infection. So those are those things, just like we see in, with teeth. I have no idea why this tooth failed. It looked good on the x-ray, but it failed. Or you get these patients where the bone is, in a sense, melting away from teeth, and you go, I don't know what it is. The same thing with joints. You know, everything's working fine, and all of a sudden, within that 10-year period, the joint fails. And it basically, they just don't know what's causing it at this point. One study found that 14% showed direct DNA links between the bacteria in the synovial fluid and plaque from the mouth. So that tells us that the plaque is basically producing bacteria that are basically getting through the system and seeding in that joint. And that's what's causing that early failure. Treating the periodontal disease can reduce the number of future costs with joint replacements. And controlling oral biofilm bacteria and periodontal health prior to joint replacement can prevent joint infection during surgical healing. And it's interesting, you know, I've practiced for 31 years, that every couple of years the American Heart Association sits down with the ADA and the AMA and all these organizations, and they say, hey, what are we going to do as far as pre-medication? And when up until probably, I think it was 2007, they just routinely pre-medicate for everything. And then basically in 2007, they sat down and they said, all right, what are we going to, should we really be pre-medicating for everything? And they said, no, if it causes bleeding in the procedure, like scaling a root planing, you know, doing a cleaning, an extraction, you know, maybe endo, it depends, putting an implant in, we were going to pre-medicate in some patients. And if it doesn't like doing a crown prep or doing a filling, you know, we don't need to. We're, you know, the thought is let's try not to build up these superbacteria that are resistant to antibiotics that we have. Unfortunately, back then, the orthopedists really didn't want to be part of the council, so and they wouldn't get really a definite answer on what are you recommending for those patients. So a few years later, finally they came together and they basically said, hey, we're going to come up with a plan. We're going to really talk about how to prevent these things, which really gave us a better approach. So I think that things are changing, and I think they're changing for the better. And fortunately, the interesting thing about, for many years in dentistry, we borrowed from medicine. And actual orthopedics has started borrowing probably over the last 15 years or so. They started borrowing back from dentistry. They're saying, hey, you guys are doing something. A perfect example is with joints. In the past, what they would do, like for a hip or something, they core the bone out, they take methyl methacrylate, which is what we make dentures out of, the denture base, and they'd essentially glue that implant into the bone, and that's why basically it would fail after about 7 years on average, and you'd have to replace that joint. Well, they started saying, hey, you guys are getting a lot of success osseointegrating implants. Why don't we look at this differently? And now most joints that are done, knees, hips, and others are basically done similar to dental implants. They're actually putting them in and getting osseointegration, and the projected now is 20 to 25 years or more they should be able to get out of this. So basically, things are coming along a lot better, and I think we're looking at total health stuff better, but we have to look at these patients who are living longer, and we may have these things in there. So the key basically, in my practice at least, if somebody comes in and they've had a hip replacement, or they've had a knee replacement, I usually advocate I want to see you religiously every 6 months for a cleaning. If we see a problem, I'm going to increase that. I may want to see you every 3 months. And there's other things we're going to wind up doing. So we want to basically prevent those joints from failing, because it's not easy when a joint fails. Like we said, prophylactic antibiotics is a treatment, one of the most important factors in preventing prostate joint infections. And we do basically, in my practice, pre-medicate when those patients have had those in the past. I don't care if it's been 6 months, a year, or longer, I'm basically pre-medicating those patients on a regular basis. There are other things, like if somebody's had a cardiac stent or something like that, usually 6 months out after they've had that done, those stents are basically totally encased in cardiac tissue, so you don't have to pre-medicate any further. But with joints, my opinion is pre-medicate really for life. Just to prevent those problems. Because the incidence of infection was 1.7% in the group receiving antibiotics versus 8.9% in the group that did not receive those antibiotics. So I think that's a significant difference in there. So I think it's better to err on the side of, you know, safety. I'd rather be in that 1.7 group than the 8.9 group. And prosthetic joint infection is a serious complication with a significant high morbidity and mortality. And I just had a patient in not too long ago who was telling me that one of their friends had their hip fail, went into the hospital, it had gotten so infected, they actually went up expiring in the hospital due to this infection. It just got progressively worse. They weren't able to replace the hip, and the patient just went downhill from there. But they were in their 80s, but people are living to 100 these days, so 80 is I guess the new 40. So in patients with prosthetic joint implants, as of January 2015, the ADA clinical practice guideline, in general for patients with prosthetic joints, prophylactic antibiotics are not recommended prior to dental procedures to prevent that. I am still erring on the side where I don't think it's a problem. I'm still giving them antibiotics just to make sure that we're not getting this. They can pick up bacteria from any different source. It could be from intestinal issues. It could be from, a scratch on the skin or something. But I want to limit what possibly may be coming from the mouth, because unfortunately those patients, as we get older, have a tendency to have more perio problems. So we are causing a lot more bleeding when we're scaling and root planing and cleaning them. So I just want to decrease the bacterial load potentially for causing problems. So according to the ADA, history of complications associated with their joint replacement surgery who are undergoing dental procedures that include gingival manipulation or mucosal incision, prophylactic antibiotics should only be considered after consultation with the patient's orthopedic surgeon. I have not found an orthopedic surgeon for any of my patients who have said, no, don't give it to them. They're all basically erring on that side also, saying, I don't see a problem with this. So in cases where antibiotics are deemed necessary, it's more appropriate that the orthopedic surgeon recommend the appropriate antibiotic regime. And when reasonable, write that prescription. So what I'm doing basically is if the patient's been taking something, I just refill the prescription. If they're a new patient, I'm going to basically get on the phone. I'm going to call their orthopedic surgeon's office, and I'm going to basically say, all right, Mrs. Smith's in the office. She's had a hip replacement that you did a couple years ago. I'm going to be causing some bleeding and stuff in there when we clean her up. I really think it would be prudent if we put her on an antibiotic, and usually the office will say, sure. Either they'll write it or they'll tell me this is what we would put her on, and I'll write the prescription and put in my notes, Dr. So-and-so, patient's orthopedic surgeon, on phone consultation with them, recommended that they be on this, and I'll write that in there. And the interesting thing is when I was in dental school, the regime was a lot different. You would take a dose beforehand, and then you take a dose, several hours later, and that basically got decreased. That's probably like 20 or 25 years ago. They basically said, no, it's really the dose beforehand. You don't need any dose after. So things do change over time. So in summary, and I guess being the ex-New Yorker, I still tend to talk fast. So we're, I guess, going to end a little early. But men with indicators of periodontal disease and prostatitis have higher levels, basically, of these issues than those who do not have periodontal disease. Men with periodontal disease had a 63% higher risk of developing pancreatic cancer compared to those reporting no periodontal disease. Infection with periodontal pathogens is associated with the progression of atherosclerosis, and a correlation may exist between patients with periodontal disease and liver disease. Women with periodontal disease may have a 4 to 7.9 times higher risk of having preterm birth than women with good oral health. This is considered a moderate to high risk. And evidence links an association between the presence of periodontal and preterm delivery and low birth weight infants. Periodontal disease and oral biofilm can affect fertility in women due to systemic inflammation, leading to difficulty in conceiving. And adverse effects of periodontal disease are more likely to be seen as in those older age groups and premenopausal, postmenopausal women. Chronic inflammation may cause tissue damage, including to the brain tissue, and this can lead to Alzheimer's disease or make it worse. And periodontitis can be marked as a low-grade systemic disease by release of pro-inflammatory cytokinins into systemic circulation, elevation of C-reactive proteins. And over 65% of all human infections are associated to be biofilm related. So treating the periodontal disease can reduce the number of future costly joint replacements, and controlling oral biofilm bacteria and perio prior to joint replacement, and can prevent joint infection during healing and surgery. And just on a side note here, if you ever have a patient comes in who's having an organ transplant, you want to make sure that you really do a thorough examination on them and get rid of anything that's going to cause a possible problem. That's perio. Get rid of any teeth that are questionable. Do endo on those other teeth, and communicate this with the physician who has sent them in with this for this consult. And I'll give you a good example. I had a patient who had kidney failure. He was getting a kidney from his sister because his 2 kidneys were failing. Came in with this thing. I said, you have all this perio issues that have to be taken care of. And he said, don't worry about it. No, I said, I'll just find another dentist that'll sign off on the form. I called up the orthopedist, not the orthopedist, the surgeon, and I said, hey, this is the issue. And the surgeon said, thank you. I'm not treating this guy and doing the kidney transplant until his perio is taken care of. So I kept, trying to reinforce on the patient that, like, you're getting a chance. There are just so many kidneys that'll match you. You want to really take care of these things, and he just really didn't really care. So do we have any questions?
We do, Dr. Kurtzman. That was an interesting, certainly little anecdote. And you think about someone who's given another lease at life, you'd think that they would grab it by 2 hands. But really, that's, I guess, the point of your story, is that you try to impress upon them that proper instruction regardless.
Well, it's the same thing with implants. Patients lose teeth and get implants because they didn't take care of their teeth. And some people, it's a come-to-God moment, and they take care of those implants, and others fall back in the same pattern. And there's not much you can do about that.
For sure, for sure. One of the comments you were just touching on, one of the first comments that we had from the audience was about the other things. When you were talking about a patient that's coming in that's perhaps been undergone some kind of joint replacement, and you referred to a variety of activities. The notes that I had from it included changing how frequently you recall them for care. It involved consultation with their primary health care provider, as well as potentially some prescription and antibiotic intervention. Are there other ways that you handle those folks differently?
It's interesting because I think it started out, I keep going back to my 31 years, but it started out we would put them on low-dose doxycycline, and they'd be on this forever, and that helped things and healing and stuff. And then the direction moved to putting site-specific antibiotics in. And we'll talk about this really in the last part, but I'll touch on it here. A lot of those things really don't help do anything to the bacteria in the biofilm. So we have to really do things a little differently. And part of that is we have to really get in there and disrupt these things. Unfortunately, the patients can't get in and do it themselves, no matter how diligent they are. You really have to basically get in there, clean that out, and sometimes get them in more frequently. And there are insurance codes basically for these patients that have periodontal problems that will cover them coming in every 3 months versus every 6 months. And you can, really justify with the insurance company this person has medical issues and that we feel that is linked basically to the periodontal problems, and therefore they need to be coming in more frequently. So I think that's important, and I think that communicating with the physician helps, because sometimes the physician will reinforce, Mrs. Smith, you really need to get back to the dentist and take care of these things. Because a lot of times when the patients have health problems, they're seeing the physician on a very regular basis. It might be every month, 2 months, 3 months. They're seeing them on a regular basis, so they may be the reinforcers to say, you got to go back and see Dr. So-and-so because you need, make sure you're getting your teeth cleaned.
I'm going to jump ahead to this question too then. If research is showing that the mechanical processes that you're describing, if that isn't effective for the patients in removing the biofilms, and antibiotics have had that same kind of, well, they're going to work, but they're not going to work, where's the research going or pointing? Where's that next investigatory step taking us as professionals?
Well, we're sort of getting a little ahead of, because we'll cover this in the last part, but I'll touch on this. There are ways basically, and the key basically is you have to make it easy for the patient. If it's not easy, the patients don't comply with it. And some patients, even when it's easy, they don't comply with it. But you have to make it as easy as possible, and then hopefully the patient it'll become routine and it'll take care of it. But there are ways of keeping the biofilm down that really basically involve trays and peroxides and stuff like that we'll discuss, that I think really make a big difference. It makes it easy for the patient compliance-wise. So I think that the direction in perio has really changed a lot over time. And it's interesting, I had the benefit of meeting Dr. Paul Kais, and if you've heard of peroxide and baking soda, you know, he was the guy in the 60s who's a general dentist, worked for NIH, really did the research on this, and all the periodontists poo-pooed him, say, oh, what does this GP know about anything? And over time, they finally accepted what he, you know, what he was talking about. And I heard him lecture, I think about 10 years ago, and he just passed away recently, and he was in his 90s. And he, you know, was telling me this story. It's like, hey, everything, all the researchers showed him, they just, what does a GP know? And a lot of that stuff now, now it's accepted theory that we can change the environment. So we favor good bacteria, get rid of the bad bacteria, because we can't really eliminate all bacteria. We just want to set up the thing. And the analogy I usually use with the patient is, think of the body as a checkerboard, and there's only one thing on a square that can sit there. And if we have good bacteria on those things, because we set the environment up like that, the body runs better. If we don't take care of this stuff, we get bad bacteria or yeast or whatever growing on those things, and that's when things get a little, cause problems.
Can you explain, I know you touched on it briefly partway through, but I think this question comes from someone who didn't quite fully understand the chronic inflammation and the ties you see between inflammation in the mouth and in the brain.
Well, I mean, basically inflammatory cytokines are basically circulating through the system, and the brain has blood running through it. And what happens is inflammation releases these compounds, these chemicals, into the bloodstream, and basically they circulate through the body, and they basically, in a sense, seed themselves in the brain, causing inflammation there, and that's basically what has been linked to Alzheimer's. And it's just like, you know, those same chemicals are seeding themselves in the liver, causing liver problems, and the colon, causing colon cancer, or leading to it or complicating it. So basically, it's chemicals that are really related to the inflammation that cause other issues. I hope that answers the question.
I think so. And in part, you talked about the diabetic patient in part in part 2 of our series. And tonight, it's basically, you can see that there's some correlated factors there. When you're thinking about the same, it's almost like the inflammation can be kind of a random manifestation in the body as a whole, given the circulatory system. Is there any kind of way that someone is more prone to one than the other?
Yeah, I'm a strong believer in genetics. I think that there are some cards we're dealt that we can't change, and there are some cards that we can change. And, you know, habits and what we're doing, we can change. We can't change our genetics, but we can basically do things that are going to basically help the genetics in a sense. And I think with diabetes, we have diabetes, you know, you can get it under control, and then you get some people who, I know somebody who really has a lot of, uncontrolled diabetes, they can't get it under control. You know, I volunteer at one of the parks, she's another volunteer, and she's telling me, oh, my dentist said, I have all these perio problems, and I can't, you know, and she goes, she never correlated between them. And she's in the medical field, so I started saying, well, maybe if you get your perio under control, it'll help with the diabetes. And she actually followed through on it. And she said, amazing, my diabetes now really getting under control, because she has an insulin pump. She was constantly having to use it. Now she says, I don't use it very often because, you know, and she goes, it really is true. So people don't put the pieces together, the puzzle pieces sometimes. And I think that really, they sort of look at them individually. Like I said, most patients have that mindset that the mouth is different. And I use this analogy, I think, the last time. I always say to patients, you have to give them an analogy they can understand. And I always say, if you brush, and this doesn't apply to you, Rich, if you brush your hair and you have blood on your hairbrush, would that be normal? And every patient goes, well, no. I go, then why is it brushing your mouth if you got blood on your toothbrush? Why do we accept that as being normal? Bleeding is never a good sign. So I always tell patients, if you're brushing, you get bleeding, you get it once, that's okay. You might have had a little cut or something in there. But if it's on a daily basis, we're seeing blood, that's an indication that there's periodontal issues going on. And we want to catch those from a dental standpoint, before it spreads into the bone and we start losing bone, and then, of course, mobile teeth, we lose teeth, we also want to make sure that we're catching it so it doesn't spread systemically and lead to all those systemic issues that we've talked about or complicate those.
Do you have the same pre-medication for each patient, or how do you manage that aspect?
You know, if somebody is, if they're not, they don't have any penicillin issues, I still think penicillin is the best pre-medication drug. So I'm basically using amoxicillin, 500 milligram tabs, 4 tabs, ideally an hour before the appointment. The literature shows that if you take it within an hour of the appointment, you're still good. So if the patient comes in and sometimes they go, oh, I forgot my prescription home, I forgot to take it, should I reschedule the appointment? I said, no, you're okay, but what I want you to do is I want you to go directly home and I want you to take those pills as soon as you get home, because that'll put you within the hour usually. If somebody is allergic to that, there are other drugs we can go to, but penicillin still, I think, is the drug of choice in dentistry.
Michael's got a quick question. I'm going to just make mention that there's also, we'll share a link with you, Michael, afterwards, so that you can go check out part 1 of Dr. Kurtzman's series, but he's asking about how long it takes for biofilm to recolonize when you've disrupted it initially.
Actually, within 48 hours, it basically rebuilds. The problem is that you really cannot, with a water pick, floss, toothbrush, whatever, you can't really get deeper than 3 to 4 millimeters. Anything below that, we're not going to be able to get to. Somebody that has a 5 millimeter pocket, we have biofilm down at the bottom of that pocket, they just can't possibly reach. So that's why coming in and taking care of this. And sometimes bleeding is not evidence. We can have somebody come in with a 5 millimeter pocket around a couple of teeth and they have no bleeding, but they still have basically potential of biofilm. And that's the importance. On those patients, we're going to say, all right, we really need to see every 6 months, make sure we keep this under control. The patients that do have bleeding, we want to basically do something a little different and maybe see them more frequently, maybe, you know, give them these trays with peroxide in them and go from there.
Okay, folks, I have a question for Dr. Kurtzman if there's no further from the team tonight. And just as a general aside, as you look at the literature, it does seem that there is this snowballing effect, that the research is coming more rapidly now over the last decade or so. Do you have some opinion on why that might be, or is it just by coincidence, or am I not reacting properly to some of those current trends in the space?
No, I think that you're pretty much on the mark. I think that as time goes on, more researchers are doing stuff, so more information is correlated, and more universities are basically pulling their data or looking at other people's data, and they start seeing that correlation. And it's interesting because, like, drugs are a perfect example. They do a study on drugs, and they study it in 1,000 people. They say, oh, it's 0.1% had an issue. And if you ever watch these commercials for every drug, it's like, I love when they say, and if for drug ABC, and if you're allergic to it, it's like, don't take it. Like, how am I going to know if I'm allergic to it unless I take it? But when they put it out in the general population, then you start seeing when 1 million people are taking that drug, now you start seeing things differently. So as they're basically doing these studies and they're pooling all this data, they're basically starting to see more correlations. And I think research methods are getting better. I think communication's getting better. And I think that that's why we're starting to see these correlations. And I think people are starting to, they're having those light bulb moments where they're saying, maybe there's, you know, something going on here where it didn't occur to somebody before.
Understood. Well, thank you for addressing that. Really appreciate it. And thank you all for joining us tonight for part 3 in this series. I would like to encourage you to mark your calendars for part 4. In just a couple weeks, Dr. Kurtzman is going to tackle a topic that's been really touched on throughout the first 3 parts of this series, which is to say the management of the periostosic connection and some of the things that you can do as professionals to step in and intervene for your patients. I would love to host you again for that next activity. And in the meantime, before you leave tonight, I'd like to encourage you to stop and fill out the post-event survey so that we can continue to hone this series and make sure it's responding to your challenges in the classroom and as you prepare for life in dentistry. Dr. Kurtzman?
And if you ever have any questions on anything dental related, I don't answer questions on politics, religion, or sports. 2 of those I know nothing about. The other one I'll get in a lot of trouble discussing it, and I have. Feel free to email me or catch me on Facebook. I'm on Facebook all the time. It could be anything related to anything in dentistry. So I hope you enjoyed it, got some information out of it, and it's going to help you move forward in your profession. Thank you.
Special thanks to you, Dr. Kurtzman. We really appreciate your time tonight, as well to our sponsors at Sunstar America making this possible. We thank you, and without your support, we wouldn't be here. Thank you indeed, and to all of you attendees who are taking time away from your studies to join us tonight. Thanks so much on behalf of Dr. Kurtzman and the next CDS. Have a great night, everybody. Bye-bye.
Thank you.